thank you, chairpersons, for this opportunity. So axial spondyloarthritis is characterized by inflammatory back pain, quite often associated with HLA-B27 positivity. Most commonly, what we see in our orthopedic practice is ankylosing spondylitis. So traditionally, it has been diagnosed on radiology, where you had X-rays to diagnose, but recently the ASAS and EULAR guidelines have moved towards using MRIs as well. And based on this MRI, it's considered a gold standard, helps in early diagnosis rather than late. If you look at review of literature, we did find publications on whole body MRIs which have been utilized for not just diagnosis, they have been utilized for identifying biological responses. They've been also utilized for disease prognostication and assessing the burden of disease, so to say. So the rationale is the whole body MRI is time consuming, cost is a big factor. So we looked at, can we use a selected screening MRI of the axial spine, looking at spine, hip, pelvis, and the traditional SI joint, and come up with a slightly lower cost procedure for the patient, which might be useful for both clinician and patients. So the study design was prospective. We looked at 100 patients who came with a clinical suspicion of inflammatory back pain, either to the rheumatologist or to the orthopedic spine surgeon. We underwent a 3 Tesla scanner, 7 sequences in all, 3 whole spine, which included T1, STIR, and T2. SI joint oblique views for STIR, that is coronal obliques, and T1 coronal obliques. Hip joints for STIR and T1. These were then classified by 2 radiologists who are MSK trained, and we used the ASAS guidelines handbook for MRI assessment. We looked at the 4 acute factors, which is bone marrow edema, synovitis, enthesitis, and capsulitis. We also looked at, since you are doing the whole spine, you can look at all the spondylitis or spondylodiscitis from cervical to sacrum. We included the hips, so you could look at pelvic enthesitis. Also looked at chronic features that could be erosions, fatty malrow infiltration, or frank bony ankylosis in terminally burnt out patients. Many of these would traditionally be missed on a solitary SI joint MRI if you advise one. So finally, in the diagnosis, 76 met our ASAS guideline criteria to be diagnosed as axial spondyloarthritis, mean age of 32, and the mean scan time for them using this selected sequence was about 28 minutes. So in features, we had 97% patients who had features of sacroiliitis, both acute and chronic combined. The second most common feature was spondylitis, which was seen in about 58% patients. The interesting finding was we had facet joint involvement, costovertebral and costotransverse involvement in nearly 40% patients. Again, thoracic spine is very commonly affected in these patients, which does not fall in the diagnostic criteria, so often missed on traditional SI joint screening. The others, including hip enthesitis, hip involvement, or frank bony ankylosis, was between 10 to 20%. So some case examples, so acute bone marrow lesion, the definition is there. So 1 positive lesion seen in at least 2 slices or multiple positive lesions were assessed. Enthesitis for the case on the right, you can see edema over the hamstring insertions in the ischium, so that could have been assessed. Hip assessment, you get bone marrow lesion in the acetabulum and effusion on the right side MRI. The left side MRI shows a typical coronal, axial T1 sequence, which was done and showed facet effusions and costovertebral inflammation. So the limitations are it's a small size, 76, heterogeneous cohort. We had both early axial spondyloarthritis and late ones. Logistically, it's not easily available everywhere, MRI, and the expertise to read such a whole body MRI is not so much developed yet. Looking at literature, so there has been papers on whole body MRI. So this was a paper by Althoff. Their scan time was 55 to 66 minutes. They found thoracic involvement in nearly 50%. In our series, it was between 40 to 50% posterior element and thoracic disease involvement. What is the use of gadolinium contrast? So this patient by Hooge et al. Showed that they didn't need gadolinium contrast in their 1 to 27 patients, and STIR and T1 was good enough. Similar findings with us. None of our 76 ended up needing contrast, or the radiologist didn't feel the need to add a gadolinium contrast to the scans. So in conclusion, selected sequence MRI with this particular sequence is good for identifying early disease. You can pick up a significant 55% patients who are having posterior involvement, especially in the thoracic spine, and vice versa. If you get a patient of thoracic spine with STIR involvement, you might want to screen the SI joint because there will be a large number of them that might be inflammatory axial spondyloarthritis. I think the stir is good enough, and you don't need quite often a gadolinium contrast enhancement. And for chronic lesions, I think T1 is very good to pick up anatomical lesions such as erosions and fusions. Thank you so much for your time.